Thank you, chairpersons.
Dr. Purendra.
Yeah. I will be now, after the good discussion on variety of IOLs, I will be sharing my experience of subluxated lens. So this is my first case, which has traumatic pupillary mydriasis, subluxation of the lens, and there is a presence of vitreous in the anterior chamber. The first thing, bimanual anterior vitrectomy is done. Just stain the vitreous, diluted triamcinolone, and check whether there is any more amount of vitreous present over there. Then you make capsular axis. I use a micro forceps for this, and this capsular axis should be decentered, more centered to the dislocated or subluxated lens. So hydrodissection is done. I am stabilizing the lens with the capsule retractor. One capsule retractor is enough. This will prevent further prolapse of vitreous in the anterior chamber. And I am polishing the capsule, and all the some amount of posterior PCO which is cleared. Now capsule retractor is removed, and I am making a tunnel here which is 2 millimeter away from the limbus, and this is 1 millimeter, and a reverse tunnel is also made to embed the proline suture knot there. And with the railroad technique, mind it, while passing this needle, you can damage the fragile capsule bag. So that has to be secured, and I am using my iris spatula so that my needle also doesn't damage the capsular bag. Now this is a Sioni ring. Multiple knots are tied to the haptic, and Sioni ring is pushed inside the capsular bag. Keep the capsule bag distended with the viscoelastic. I don't use any high-end viscoelastic. I use only carboxymethyl cellulose. And the bag is now centered, and a single piece lens is placed inside the bag. And then remove all the viscoelastic from the anterior chamber. Check for the presence of any vitreous in the anterior chamber. These small tracks were there, and with the same retractor, with the IA mode, I am just reducing the size of the pupil, and this will decrease the size of the pupil, and that is going to decrease the glare part of this young patient. So this is my first case. Another case, this case because this is the area of maximum zonal dialysis, and I have to use a double Sioni ring because it is almost 270 degrees subluxation from this part to this part. So again, a capsular axis is done in a way which you are comfortable with, and 4 capsule retractors will be placed to the CCC margin, as you can see, and this will stabilize the lens on 4 parts, and 2 proline sutures are used, and this is a double Sioni ring. One can use single Sioni ring and a capsule traction ring segment to stabilize at 2 places, and it is brought in the capsular bag in the area of maximum zonal dialysis, and 2 sutures are tied to the scleral tunnel bed, and the knots are buried. Some problems are there when you remove these, when you tie these knots, because they try to make this thing, the sutures get entangled on both sides, so that has to be kept in mind. So this is the post-op picture of the same patient. But, this is interesting thing. Patient came to us with the 32 years old lady came to us with the decreased vision and myopic correction. So she went to some place, and she was advised a laser correction, corneal surface procedure. So when I dilated the pupil, I found that on pentacam there was no cylindrical power, but here it was -4.5 diopters of cylinder. And some nuclear sclerosis and posterior subcapsular cataract was also there, and there was a subluxation of lens. Then she gave us the history that she had a trauma 11 years back. So we did a laser assisted cataract surgery, and this is how This is the area of zonular dialysis or subluxation. We have to decrease the size of the capsular axis, and we have made it eccentric as it is the demand of this subluxated cataracts. Rest of the technique is similar as we have done it. So in these cases, the subluxated cataract cases, laser-assisted capsulotomy and surgery is very, very helpful. And as we were discussing during the first laser-based cataract surgery talk in the first go, and then we found that some vitreous was coming in the anterior chamber, so we did a vitrectomy and stabilized the lens bag and puts the CO ring inside the bag after distending the bag with the viscoelastic, and a similar technique is adopted. So this is the post-op picture of the same patient, very well stable lens bag and the IOL well centered, well covered by the capsular axis. There is another case we did in the similar way with the help of laser cataract surgery. This is another interesting case. We have to manage differently because we had had a lot of problems during the procedure. So first, in this case where the bare vitreous is there, you have to fill the chamber and cover the vitreous with the viscoat, and to prevent further prolapse of vitreous in the anterior chamber, and multiple capsule retractors are placed so that the lens bag doesn't get torn at the capsular axis margin by the traction during the phacoemulsification. And this was a dense cataract. As you can see, grade 3 cataract was there, and you can complete it in a routine way. Only thing is that you have to decrease the parameters of your phaco settings, and a CO ring is placed. And I was doing in a routine way. When we place the tunnel very close to the main wound, then we bend the needle so that it can pass easily. Now at this place, what happened? Just 30 seconds more. Pulled this lens bag has got damaged on the other side. I have damaged those zonules on the opposite sides also. So on the right side, my zonules were weak, pre-existing weakness was there, and now by the pulling of the suture, I have created zonular dialysis on the other side. And good part is my CO ring is inside the bag. And then what I did, I released the suture, Prolene suture, and got a new Prolene suture with the 2 straight needles. So one loop is passed from within the CO ring, and then it is tied to the sclera. And there was a PC dent also in this case. Then a 3-piece lens is placed in the sulcus, and an optic capture is done in the capsular axis because my capsular axis was intact. So this will prevent the lens to fall back in the vitreous cavity because I have engaged the optic of the lens in the capsular axis. So this is the post-op picture of the same case. This is the ovalization, and this is the rent in the posterior capsule. But the lens is stable. So various other cases. So we can do Zimane technique also, we can do scleral fixation, we can do. So this is what it is. So to conclude, this is a good technique. If you are able to complete it, you complete it with this technique. Otherwise, you can do a retroiris fixation or other kind of lens fixation.
Thank you, Purendra. Thank you.